Next speaker is Dr. Shweta CHAURASIA.
Good afternoon. There are no financial disclosures. CFM is a rare genetic condition which affects extraocular muscles, and it is caused because of the maldevelopment of third and fourth cranial nerves. And it has three phenotypes. CFM1 is mainly caused by mutation in KIF21A, and CFM3 is caused by TUP3 mutations. So in this study, we aim to prospectively investigate the clinical manifestation, genetic and imaging characteristics of Indian CFM cohort and their management strategies. We also aim to perform phenotypic and genotypic correlation. It was a prospective study done in PGI Chandigarh from October 2018 to October 2024. The included patients were congenital non-progressive restrictive ophthalmoplegia with or without ptosis with post-op follow-up of at least 6 months. Exclusion criteria previously operated patients. All the patients underwent oculomotility and ophthalmic examination. MRI imaging was done. CIS sequences were done to image the cranial nerves. Quasi-coronal MRI orbit was done for the cross-sectional area, and the dynamic orbit in the various gauges were done. Whole genome sequencing was done for the genomic DNA extraction mutational analysis. The exonic regions were sequenced using the Illumina NovaQ platform. The DNA were fragmented and coding regions were selectively identified, and identified variants were annotated and filtered through the Golden Helix platform. Coming to the results and discussion, there were total 18 patients, 8 male and 10 female were identified. There were 6 pedigree, 6 sporadic cases. Average age was 11.25 years. All showed autosomal dominant inheritance patterns with heterozygosity. Anterior and fundus examinations were normal. None of the cooperative patients had binocular vision. CFM1, there were 15 patients in CFM1 phenotype. All had ptosis with upgaze palsy with infrarrectal globe position, chin-up posture, and perverted convergence in upgaze and divergence in downgaze. There were 3 patients of CFM3 phenotypes with either asymmetrical restrictive strabismus or brain malformation. Coming to the imaging findings, all had relatively thin cranial nerves, and there were 2 patients of hypoplastic sixth nerve in CFM1 phenotype. There was parenchymal atrophy in 1 patient and thin corpus callosum in 1 patient. Muscle attenuation was present in medial rectus and SR-LR complex. You could see the mean value of the medial and superior rectus was much less than the normal population here, and the mean compared to the mean LR, compared to their own LR, the medial rectus and superior rectus were 23 to 25% thinner than the lateral rectus. Dynamic orbit was done in 5 adult cooperative patients, and synergistic convergence was demonstrated in 3 adult patients, and synergistic divergence and synergistic innervational downshoot was present in 2 patients each. Coming to the genetics, there were 9 patients of KIF21A and 9 patients of TUP3 mutation. KIF21A code for kinesin protein, and TUP3 code for microtubulin protein. And kinesin dimer attaches and moves along the microtubules, and this is important for the human nervous system development. So in the 15 CME of CFM1 phenotype, generally it is caused by KIF21A mutation, but in our population, there was 60% involvement of KIF21A and 40% of TUP3 involvement. Whereas in the case of CFM3 phenotype, there were only TUP3 mutation was present. This is because of the phenotypic overlap between the CFUM, TUB and KIF21A, which suggests a shared disease mechanism underlying the 2 disorders. This is the table of KIF21A. So there were 6 patients of missense variant mutations, and there were 2 patients of deletions and 1 patient of duplication. The C2821 was the most common mutation in our series, and comparing the literature, we didn't find this mutation anywhere in the literature. This is the C2821. You could see there is a synergistic convergence in the up gaze and divergence in down gaze, and there was adduction deficit along with the synergistic and innervational downshoot. In the MRI finding, there were thin corpus callosum, there was diffusely thin third and sixth nerve, and there was superior rectus and medial rectus thinning was there. And there was a Y-shaped muscle, accessory muscle at the posterior orbit. This is the C2821 patient showing left eye adduction deficit and innervational downshoot, and you could see in the left side the medial rectus is thin. In the TUP3 mutation, this is the exhaustive table. We had 6 patients of missense mutations and 2 patients of deletions. This is the TUP3 C211 patient showing this is the right gaze, and this is the down is the left gaze, and you could see there is a synergistic innervational downshoot. You can see this is the inferior rectus, which is in the right gaze, and the same inferior rectus has increased in bulk in the left gaze, showing in a synergistic innervational downshoot. Coming to the management, bilateral supramaximal recession of IR and LR was done in 10 patients, and LR periosteal fixation was done in 2 patients. Bilateral superior oblique weakening was done in 4 patients, and inferior rectus to medial rectus transposition was done in 2 patients. These are some of the photographs of the patients after inferior rectus recession and LR recession. This is another patient. This is again the photograph of another patient after IR recession and LR recession. This is another patient. This is the patient of sole KIF21A duplication, in which there is only adduction deficit in the left eye along with the synergistic innervational downshoot, and inferior rectus to medial rectus transposition was done with a good surgical outcome. And we have already described this synergistic innervational downshoot in our previous paper. So the take-home points are the KIF21A and TUB3 are both can constitute the CFUM phenotype in our Indian cohort, and C2821 was the most common novel KIF21A mutation in Indian cohort. Compared to the literature, the sixth nerve could also be involved, which we have seen in the previous literature also. Brain parenchyma atrophy can be present, and MRI imaging is crucial in identifying the structural abnormalities of CFUM. The limitation of the study, though we had 18 patients, but still it's a small cohort, advanced imaging is required and further genetic workup is required. Coming to the conclusion, genetic analysis is critical for diagnosis and understanding. Imaging is essential for assessing the structural abnormalities, and titrated surgical therapy is important depending on the FDT and misinnervation, and the future research is required to expand cohorts and advanced imaging. Thank you.
Thank you. So did you find any correlation with the genotype, phenotype, so that you can put into after clinical examination? You can say this may be KIF or the TUB1.
Yeah. This is the, I think it's not, we have done the phenotyping and genotypic correlation, and we have seen that in C2821 population, we had 2 pedigree, 4 patients of family who had misinnervation, synergistic convergence, they had synergistic divergence, they had synergistic innervational downshoot, they had, but the sporadic didn't had the misinnervation. So this was the correlation of genotypic and phenotypic. Moreover, we have got all the patients with CFUM 1 phenotype. But we found in the literature it is available that KIF21A gene is mainly responsible for 1 phenotype and TUB3 is for 3. But in our population, 60% of the population were KIF21A and only 40% and also 40% were TUB3 in 1 phenotype. So this was,
you cannot say that.
yes, just solely by the 1 phenotype that it will be KIF21A only and not TUB3.